Hello, my name's Dr Tonia Mezzini and I'm a sexual health physician here in Adelaide. Thank you so much for the opportunity to talk to you about PMOS. Try saying that one 3 times quickly, it's a bit of a tongue twister. PMOS used to be called PCOS, and as of June the 6th, from an article published in The Lancet, which is a very well-renowned medical journal, there has been a huge amount of discussion about what this change means for women. And what I'm hoping to do today is talk you through what PCOS, PMOS means, how you might approach understanding what's going on for yourself, and how you might approach conversations with your GP or your gynecologist or your sexual health physician to help you to navigate this new landscape. All right, so what I also need to say to you though is that the information that I'm providing to you today is of a general nature. I can't address your individual healthcare concerns, in a format like this. So this is a really general talk that hopefully will give you some ideas of where to go to look for some more information. And the final slide will be some resources that you can look at so that you can research things for yourself. Okay. So traditionally, the way we've diagnosed PCOS is that if you were over 20 and you're an adult, you needed to have 2 out of the 3 following criteria. Oligoanovulation, which is the Latin word for irregular periods. And what we mean by that is a cycle that's shorter than 21 days or longer than 35 days. So either a very short cycle or a very long cycle. Number 2 is clinical or biochemical evidence of hyperandrogenism. And what that means is either in the symptoms that you present or the blood tests that you have evidence of high testosterone or the male hormones. And that usually manifests as acne, excess facial or body hair, or thinning of hair on your scalp, or high testosterone levels on blood tests. You can have all of those or just one. And then what we would call polycystic ovaries on an internal pelvic ultrasound or an elevated anti-Müllerian hormone. So that's a blood test. It's not easy for everyone to have a transvaginal ultrasound and a transabdominal ultrasound. So transvaginal is a scan through the vagina with an internal probe, and a transabdominal scan is one that's done through your tummy. It's not always easy to see your ovaries on a transabdominal ultrasound, but not always appropriate for young women in particular to have a transvaginal scan. So this is where it all starts to get a bit tricky, and this is what we're moving away from. To meet that criteria for a diagnosis in young people, so adolescents, and we would define adolescents here as women aged between 10 and 19 years of age, we would look for irregular periods and high testosterone. The problem is that when you first start getting your periods, they're invariably irregular, and in fact it can be quite normal for at least the first 2 or 3 years of your menstrual life to be irregular. And then it goes irregular again at the end of your reproductive lifespan. So what we now have is PMOS. So instead of Polycystic Ovarian Syndrome, which suggests that the primary problem is with ovarian cysts, we now have the name Polyendocrine Metabolic Ovarian Syndrome, which is meant to reflect the whole body nature of the condition. So this is not just one hormone that's going wrong, this is multiple hormones that are interconnected that aren't signalling in the way that they need to, and they tend to all overlap and are interconnected. So P in this sense stands for polyendocrine, meaning multiple hormones. M is for metabolic because there's an increased risk of developing health conditions such as type 2 diabetes or cardiovascular disease, so heart disease. So high blood pressure, high cholesterol, again, all tied back into metabolism concerns. O is for ovarian, so we haven't forgotten about the ovaries, they're just not the fulcrum around which the diagnosis rests. So on a pelvic or transvaginal or transabdominal ultrasound, you might see multiple immature follicles, which are small fluid-filled sacs in the ovaries on ultrasound, but it's not on everyone. The problem is what happens is that the message to release an egg for ovulation to occur doesn't fully translate across. So the ovaries make an egg, make a follicle, which is the little bag that it sits in, but then can't quite get it together hormonally to actually release the egg. And so then you have problems with your estrogen and then problems with your testosterone. So it's almost like your ovaries try to ovulate but can't quite get there. And then when you don't ovulate, you don't get a period 14 days later, because by definition, a period is a withdrawal bleed when the hormones drop 14 days after you've ovulated. S is for syndrome, reflecting the multiple symptoms that are involved, affecting both physical and mental health. So how we diagnose PMOS now, still with irregular cycles. So cycles under 21 days, longer than 35 days. Number 2, multiple immature follicles, small fluid-filled sacs on the ovaries, and generally more than 20 per ovary. So you have to have a really good quality pelvic ultrasound, and they've got to count each tiny little pelvic, every little follicle. Excess hair, which we call hirsutism. So that means on your face, so upper lip, sideburns, chest, stomach, back, upper arms, thighs, places that ladies generally don't like to have excess hair. And then you lose hair from your head, so you get thinning of the hair on your scalp, and women often complain that the part line in their hair is a little bit wider, or that they recede a little bit from the sides. The skin changes are often reflected with acne, and hormonal acne tends to be along the jaw and along the cheeks, and it's often quite cystic and painful. So they're big pimples, not just a kind of few little pimples on your nose. And then other skin changes that we call acanthosis nigricans, which means dark brown sort of velvety changes on the skin, particularly in the groin and under the armpit. And then we also now consider all of these other factors. So those criteria haven't changed, but it's not so much of a ticker box approach, it's more looking at your body holistically. So we also consider that with a diagnosis of PMOS, there can be anxiety and depression. And we don't know if it's the hormonal changes that impact on your physical well-being that cause the mood changes, or whether the hormonal changes actually change your brain biochemistry in and of itself. There's a lot of sort of chicken and egg with this system. Women will often report difficulty losing weight, so they have insulin resistance, and then that insulin resistance means that they put on more weight through their middle, and we know that that metabolically active weight tends to make more insulin resistance, and then it can be associated with fatty liver, which makes more insulin resistance and more metabolism concerns, and then that can lead to type 2 diabetes, which makes it even harder to lose weight. So you're trying really hard, you're not getting anywhere, and then as you gain weight, your blood pressure goes up, and your blood pressure goes up and your cholesterol goes up, and then that can impact on your mood. It can also impact, those metabolic changes can impact on things like sleep apnea. So if you put on weight through your neck, when you sleep at night and your airways relax, you're more likely to snore, it's more likely to close over, then you don't sleep as well, so you're more tired during the day. When you're more tired during the day, you're more likely to crave carbohydrates, so then you gain more weight, and it goes around and around in a circle. Then tied with that can be negative body image, and it can sometimes be unhelpful for people to say, well, you know, just try harder with diet and exercise because you're already trying hard but you're not winning because your body's not working with you. And then that can sometimes lead to stress and anxiety, and sometimes even lead to eating disorders because people are trying really hard and not getting anywhere. It can also have consequences for fertility and pregnancy issues, because you need an egg to be able to conceive. So if you don't ovulate regularly, there's not an egg regularly, and then therefore the egg can't meet the sperm, and therefore you can't make a baby. So if you're not ovulating regularly, that's how PMOS impacts on fertility. But we also think that there's some inflammatory component to the metabolic concerns, which is why we use metformin to help people to conceive. But I'll get back to that as we go further along in the talk. And we also know then for pregnant women with a background of PMOS, they're more at risk of gestational diabetes, which is diabetes in pregnancy, which can mean that the babies are bigger, and that can mean a more difficult labour, and it can mean some impacts for the health of the baby when the baby's born, because then the baby's blood sugar levels drops. So this is a whole area that needs attention. So clearly we're not just talking about your ovaries. And I would have to say that we've known all of these impacts of PMOS for a while. Most of us have been working in the area of looking after women with PCOS, have understood that that criteria isn't something that we necessarily rigidly adhere to, because we do see a whole range of clinical presentations and women complaining of all of these issues, but we've been stuck because formally, officially, we've had to stick to that diagnostic criteria. Now we can open that spectrum up and we can open that understanding up, which means that women are better able to access care. And I'll talk about GP care plans in a minute. So, what causes PMOS? We actually don't know. It's a complex condition that's influenced by your genetics, so your family history, environmental factors, behavioural factors that all feed into one another. The hormonal changes and the ovarian changes, and I'm just thinking, when we say hormones, we don't always just mean estrogen and testosterone. We mean insulin, that's a hormone. We mean thyroid function. We mean all of those, any chemical messenger system in your body is considered a hormone. And we don't know which one causes what, but they do tend to be intertwined and they can escalate and exacerbate one another. And that's why we need a coordinated approach to care, because there is not one thing that anyone will be able to do to help you to manage this. And the things that work for you might not be the things that work for the next woman with PMOS, and it really needs to be an individual approach to care. When we talk about risk factors for PMOS, so people ask, how can I prevent this? Well, as we've said, we can't change your family history, but we do know that other things that increase the chances of you having problems with PMOS are smoking. It's bad for you on so many levels, so just stop it. That includes vaping. Exposure to pollution, so plastics, parabens and other chemicals that we call endocrine disruptors. This is why you might have seen that there's a bit of a shift from storing food in plastic containers to storing it in glass, moving away from silicons in our cookware, using ceramics, that sort of thing. A high calorie diet, so anything that causes you to put on excess weight will also then feed into that insulin resistance and then have that flow-on effect of affecting your ovulation. We don't know what diet is best for PMOS. We generally think, however, a diet that's lower in carbohydrate and something like the CSIRO Wellbeing Plan, which is sensible, well-researched and modelled on a Mediterranean diet, probably has the best evidence overall for health and well-being. Any crazy diet that involves skipping food groups or eating lots of one thing and not much of another, generally that should raise a red flag, because you can't stick to it and you're not meant to be miserable for the rest of your life. Not doing enough exercise, we know, can impact on PMOS, because when you exercise, particularly if you do weight-bearing exercise, you're more likely to increase your muscle mass. If you increase your muscle mass, your basal metabolic rate will go up, and then your metabolism is working harder. It's working with you, not against you, just even when you're resting. And one of the things about aging that makes this stuff even more difficult is as we get older, we lose muscle mass. And by older, I mean over 35. So, it's pretty brutal. And carrying extra weight, again, because of all of those other flow-on effects with your metabolism that can influence ovulation and then your sex hormones. So the bit that you probably all want me to get to is what to do about it. So absolutely education, and this is why we do these talks and try and pass on this information, is so that you can understand what's happening to yourself. Having that label can be really validating and normalising and help you to understand that it's not it's not your fault. It's not something that you're not trying hard enough to fix. And it should help you to know that it's a really common condition. Something like 1 in 8 Australian women are affected by PMOS. So you're not alone in this. And absolutely, we should be putting more resources, thank you federal government, to supporting our care and treatment of this. Working with a nutritionist would be crucial. Someone who can help you to match your lifestyle and the foods you like to eat and achieve your healthcare goals. And maybe you've got some food intolerances that you need to work around. Absolutely, that's what a qualified nutritionist can help you with. For the lifestyle strategies, we talk about exercise, weight-bearing exercise, stress management, we all need to work on that. psychological support to help you to cope with sometimes something that can feel really overwhelming and hard to navigate. Even simple things like laser hair removal can be really helpful, and some clinics, if you've got a letter from your doctor saying that you do have PMOS, will offer a small discount for laser hair removal. So find out who they are. In terms of medicines, there's a whole range of things that we recommend. Number one is the combined oral contraceptive pill. And we use that because the oral estrogen in the combined pill pushes up a protein in your blood called sex hormone binding globulin, and that then pushes down your testosterone. So it's an anti-testosterone medication in this sense. It also helps to regulate your cycle so that you have a regular withdrawal bleed, and then that reduces the chances of something called endometrial hyperplasia, which is where the lining of the uterus thickens and doesn't come away, and that's the problem with only having 2 or 3 periods a year. As a minimum, if you're not on any hormonal contraception, you need to have 4 withdrawal bleeds a year. Otherwise, there's a risk of endometrial hyperplasia. So the pill can help to prevent that. So can the Mirena IUD or the Kalena IUD, but they're not as good at suppressing the testosterone because they don't suppress ovulation. But again, that needs to be an individual conversation with your clinician. It might be that you can't tolerate the oral contraceptive pill, or you get migraines with aura, which is a reason why you can't have the oral contraceptive pill. So it's a discussion point, needs to be tailored to you. The other point about the oral contraceptive pill is that it helps if we can use one that's got an anti-androgenic progestin. So the pill contains both estrogen and a progestogen, which is progesterone, the synthetic version of it, and they all have slightly different recipes. So different estrogens are tolerated differently, different progestogens are tolerated differently, and some of them are better at suppressing testosterone than others. Then there's the testosterone-lowering medications in and of themselves. So spironolactone, which is a tablet that we also use to lower blood pressure. That can be very helpful. And as can minoxidil, which can be taken orally or used as a foam to help with hair loss. And a dermatologist might prescribe that for you. In terms of other dermatological conditions like the acne, so we might be looking at using something like Roaccutane, oral antibiotics, topical benzoyl peroxide. So there's all sorts of combinations of tablets that you can take, as well as topical treatments to help manage your skin. The anti-hyperglycemics, so this is the class of drugs like metformin, which can help with reducing your insulin resistance by making you more sensitive to insulin, so it works better in your body. And then one of the newer class of medications is the GLP-1s. So these are the injectable weight loss medications, but they're also designed to boost metabolism. And very small doses of these medications can be enormously helpful for women who have been battling with the metabolic concerns of PMOS. Now, you might also need some assistance with fertility if that's the stage of life that you're at. And there are a whole range of options that we use here as well. So we use letrozole, which is an aromatase inhibitor, clomiphene, I can never say that, it's spelled Clomiphene, with or without metformin. Zoladex and Cineral are medications that we use to stop ovulation. So a lot of the fertility medications that we use are designed to control ovulation. And then we sometimes even use ovarian surgery. So we do laparoscopic ovarian drilling in order to lower excess androgens, restore the ovaries to their normal hormonal balance so that you can have a spontaneous ovulation. But your gynecologist or fertility expert will talk to you about what is appropriate for you. But of course, undermining or underpinning all of this is the lifestyle interventions that you can do. So we know that if you can reduce your weight by at least 10%, that massively increases your chances of spontaneous ovulation. So working with your nutritionist, your exercise physiologist is key. So how your GP can help you is with something called a GP chronic condition management plan. So as well as helping you with diagnosis, so ordering some blood tests, talking to you about tracking your cycle, screening for other hormonal conditions such as low thyroid, which is important to exclude. A GP can, with the assistance often of their practice nurse, put together what's called a chronic condition management plan. So this allows you, if you've got a chronic medical condition that's been existing for more than 6 months, then you can see an exercise physiologist or a nutritionist, so an allied health practitioner, for 5 visits a year, subsidised by Medicare. The other option that you have is a GP mental health treatment plan, and that allows you to see a psychologist for up to 10 visits per year. So when you ring your general practice, let the receptionist know that you need a long appointment, because you need a longer appointment to plan these and to talk about them, and that you want to do a care plan, whether that be for allied health professionals or for a psychologist, and that visit is automatically bulk billed as well, so there's no out-of-pocket expense for that. So that's an initiative that's been around for a long time, courtesy of the federal government, to support access to other healthcare professionals other than just doctors. So, in summary, PMOS is a complex, long-term hormonal disorder that can affect your physical and mental health. But there is a whole lot that we can do about it, and we're increasingly seeing a range of medications that we can add into our toolkit to help you with it. If you have a range of symptoms, including irregular or absent periods, skin issues, weight changes, mental health concerns, then talk to your doctor about the possibility of PMOS. Treatments depend on your symptoms. They might include lifestyle changes, hormones, metabolism medicines, depending on where you're at in your personal journey with this and what your goals are. And finally, I just wanted to direct you to some resources that you might find really helpful. So the Jean Hales Institute for Women's Health has a fantastic set of resources that you can work your way through, and they've even got a checklist that you can do and take to your doctor. Helena Tiede is a professor of endocrinology from Monash University who has been working in this space for a long time, and she was the one who's the lead author for this article that was published in The Lancet. And because it's such an important piece of work, you can access this journal article in The Lancet without any particular library access or without any special codes or needing to pay for it. And we do this in medicine when there's a piece of information that's published that is considered to be so important that everybody needs to access it. So all you need to do is use your search engine to find the Tiede article, and if you put into the search engine www.thelancet.com and it's volume 407 during the 6th, then the article about PMOS will come up, and you can also see then all of the discussions that other doctors have had around this name change, so you can understand it for yourself. You'll be an expert before you know it. So I hope that's been helpful. If you've got any further questions or concerns, then drop us a comment below and I'll see what I can do to try and answer them. Take care.